Week 4. Thank you, Vic. Can you hear me, Doriana?
I think she's frozen.
Yeah, she's definitely frozen.
Week 4, I think, today.
All right, well.
Why?
Once she gets back on, guys, again, this is week 4, I guess, for her. And she's going to be talking about medical marijuana use, when to use it, how to use it, what we know about it, what we think it's doing, and what it's actually doing. Challenge her with questions. She's frozen, so challenge her, ask her whatever questions you want. And I'm sure the more we talk, the more insight we're going to get. She's gone. I guess she's probably going somewhere else in the house. Perfect. To get better connection. And if you know any medical marijuana users, you know you can add them. It's so cool how you can add people to the Zoom. You can go like when you go to participants and you go to invite, you can go straight to your Facebook Messenger, and it just lists and just gives everyone that link, which is pretty cool. So
Guys,
Chris,
sorry.
That's okay.
Can you hear me?
Yeah, we can hear you.
Okay, my connection is really unstable today. I don't know why, so I just moved locations. So I don't know if I'm moving around. I'm just trying to find a spot in the house that actually is working.
Yeah, it's all good. We have that experience almost at least once a day, Steve and I, with the music or the connection, and like there's no reason. It's like, why isn't it working?
Yeah, today's is great. Yeah, it's so bizarre. So I'm like sitting on a half wall in the middle of my kitchen now. A bit odd. That's okay.
Works.
Hold on, I just have to.
I gave the introduction. I said, so this is week 4 of you doing the talk, unless it's week 5. It is week 4?
I think it's 4.
Okay. Week 4. Sorry, I'm not doubting you, Vic. I'm just double checking. So yeah, we're going to be talking about medical marijuana use, what it does, what we think it does, what it actually does, how to use it, and whatever questions we can ask you and challenge you with and all that jazz. Because I'm sure there's a lot of people who have a lot of bro science, right? And swear by what they believe and think, but it'd be nice just to get some perspective from someone else.
Yeah, well, I mean, the first thing I'm going to say right off the bat is I am not a pain specialist. Okay, so this is definitely not my area of expertise. And again, I had to do a lot of research, so it was good for me too. But yeah, so I mean, everything that so I'm going to talk mostly about stuff that probably is stemming from research from 2018 and onwards. Try to keep it as recent as possible, but I think the whole field in general is just so evolving so quickly. So things are kind of always changing, it seems like. But let's just I was just going to sort of go over just the basics, right? So that we have an understanding of what this actually is. So we're talking about marijuana, medical uses of marijuana. So marijuana is a plant. Well, that's like as basic as you can get. But so medical marijuana uses the 2 main components of the plant, the CBD and the THC component, right? And those are the 2 components of the plant that are used for medical purposes. So the body itself, okay, so our bodies have what we call an endocannabinoid system. Okay, so we actually have receptors called CB1 and CB2 receptors in our body. Some of those receptors are in our central nervous system, meaning the brain and the spinal cord, and some of those other receptors are peripheral receptors, so they're in the peripheral nerves, okay? And when you're talking about cannabinoids, which are the class of drugs that we're talking about today, there's 3 main sort of groups of them. So there's the endocannabinoids that are the ones that our bodies produce. And then there is the synthetics that are made, okay, to mimic what the naturally occurring substances in the marijuana plant does. And then there's the CBD and THC that you find in the plants. Okay, so what we're doing with medical marijuana is we're taking those substances and we are using them in our bodies where we have those receptors that would be working naturally anyways. So is that good? Any questions there? Everybody's good? Can you guys just give me a thumbs up because I can't really, oh, I know why, everybody's on mute. Okay, I was like, why is it so quiet? Okay.
Good morning, thank you.
Okay, good. So CBD and THC, I think most people know this, but CBD is the component of, we'll call it marijuana just for lack of, we can call it cannabinoids, but just the general term is marijuana. Okay, so CBD is your non-psychoactive component. Okay, so that's the component that does not give you the high. THC is your psychoactive component that does give you the sort of high that we talk about when we're talking about marijuana. Okay, so let's just start off with like a couple sort of quick things to get them out of the way, right? THC, like I just said, is the psychoactive component. And I think that when we're talking about THC, whether it's for recreational use or medical use, we have to be aware of the limitations that we have, okay? Or the contraindications, okay? So just to kind of get this out of the way, because it's a psychoactive substance, there are some conditions where we have to be careful, even if we're using it medically, for medical purposes, okay? So the big one here that comes to mind is people who have a history of psychiatric disorders, specifically psychotic disorders. So things like schizophrenia, okay? We have to be very cautious or not use at all in that population because it can exacerbate a psychotic episode. The other people that have to be careful are people who've had recent heart attacks, people who have issues with alcohol abuse or are on other medications, for example, like benzodiazepines. Okay, so those are sedatives because it can interact and cause an accumulation of side effects. And people who have to drive, okay, or operate heavy machinery have to be cautious. And then people with just a history basically of things like depression, right? We have to remember this is a central nervous system depressant, okay? So marijuana depresses the central nervous system, which a lot of people like those side effects because it makes them feel calm and sort of, takes anxiety down. But the flip side of that is that it can also cause a lot of amotivation, difficulty in school and work performance, that kind of stuff. Okay, so that's more probably the recreational side of things, but still have to consider those side effects with THC for medical use because they are side effects. Okay, and then there's also interaction with other drugs, which I think we don't know as much about, but the interaction that this might have with some of the other drugs that are metabolized by the same body systems and enzymes that other drugs are metabolized by. Okay, so that's just kind of like the basic science around CBD, THC, that kind of thing. In terms of how it's for medical marijuana, it comes in a lot of different forms. So when you look at medical marijuana, and I'm telling you guys the researches and the resources, which I'm going to give you at the end of the talk if you want to look at any resources in further detail, but they're vast. Like there's a ton of stuff, right? Again, you have to be careful what you're looking at. So I'm going to give you some good websites to go to, but so you have the smoked and inhaled forms, the vaporized forms. You can do CBD oil, which can come as drops or capsules. There's edibles. There's also topical CBD that you can actually apply to an area. So that's so that is sort of the realm of how it's, also synthetics, the realm of all the supplied forms. Okay, so the synthetic forms are the ones that are manufactured synthetically, right? They're analogs of the naturally occurring THC and CBDs. So when you look at the differences, because that's the other thing, is that they act so differently. So when you look at the smoked forms of marijuana, there are certain things there when you're using them for medical purpose that might give a patient some benefits, right? It's very quick acting. So when you're using smoked marijuana, the onset of action is very quick, right? Within minutes usually. And the effect happens really quickly. So in a way, it's easy to titrate, right? Because we know exactly when you're starting to feel that effect. Oral cannabis takes longer to set in, okay? So now we're looking at usually about an hour for the onset to occur, and it lasts a lot longer, can last anywhere from 4 to 12 hours. So again, totally has its place in practice for medical purposes, but people who are not doing it, and this is going to be my key message in this whole talk, people who are using it not in a medically supervised way have to be careful with that, because you take an edible, half an hour later, you don't feel anything. You're going to take more of an edible. Steve's laughing. Steve told us the story. I remember that story. So it's much easier to, I'm going to say, quote unquote, overdose. Okay. Overdosing on THC is very, very difficult. Okay. You really, there is no, it's not like an opioid, right? But you can certainly develop cannabis toxicity, which definitely has symptoms, you know, that I'm sure you've heard of, possibly experienced. But they can be fairly green out, Victoria. But the toxicity symptoms can be very unpleasant, right? Nausea, vomiting, cognitive impairment, you know, a slew of things. So that's, you know, something to be considered when you're using orals. Okay, so that's just kind of talking about the forms of cannabis or cannabinoids in general. Okay, then, so, you know, when you look at the research and the studies, there, you know, it seems like we're trying to find any possible use for cannabinoids, right? In all sorts of different medical conditions. I think for today's purposes, I think our goal was to talk about pain, mostly how it's used in pain. Because obviously it is used in other realms of medicine, palliative care, like fibromyalgia, epilepsy. So it has a lot of research, and it's used a lot in controlling epilepsy. But for our purposes today, it's going to be pain. So when we're talking about pain, right? Pain is not just pain. There's two types of pain. There's acute pain and there's chronic pain, and they are very different. So what I kind of delved into a little bit was, you know, what is the use of medical marijuana when you're talking about acute pain versus chronic? Chronic pain is a very complex condition. You know, chronic pain by definition is pain that has not resolved after 3 months, because that is the amount of time that you should expect tissues to have healed and pain to have resolved after whatever injury or disease you've experienced. Okay, so pain that lasts longer than 3 months is considered to be chronic pain, but it involves a whole different set of complex pathways in our body, in our nervous system, different from acute pain, which is kind of, you know, an acute insult, you get pain and it resolves quickly. So when we're talking about medical marijuana and pain control, how does it work? The evidence that we have so far basically shows that it helps with, you know, decreasing inflammation and decreasing the amount of pain that we feel, right? Our pain perception and our pain sensitivity. So by and large, it is very, the studies have shown very little evidence for benefit in acute pain, okay? Acute pain and postoperative pain. Those two conditions really don't have a whole lot of good evidence to show that medical marijuana works for those purposes. In fact, there have been some studies that have shown that that using using THC for acute pain in low doses maybe helps. In high doses can actually make pain worse. Okay, so you have to be careful with that. Chronic pain is entirely different. So chronic pain, we definitely have a lot more consistent data to show that it can be helpful. Again, there's very many different forms that it can be used in. Not as much studies, not as much evidence behind muscular pain, okay? As opposed to chronic pain, we're talking about things like osteoarthritis, pain and spasticity due to certain conditions like MS, Parkinson's disease. What else? Pain, neuropathic pain. So that's a big use for medical marijuana. So neuropathic pain is pain that is caused by nerve damage. Okay, so we see that in diabetics, in HIV patients. So that's a big one for neuropathic pain. There actually is quite a bit of evidence for that. We talked about MS and osteoarthritis. Headaches, so chronic migraines can sometimes, it can be used for that as well. So I think for our purposes, you know, very little stuff came up, and I don't know, it could just be lack of research so far in terms of when you look at performance and, you know, sport performance and recovery. The major conditions that, you know, medical marijuana is used for these days are I would say the bulk of them is for pain, palliative care. So things like chemotherapy-induced nausea and vomiting, anorexia from different medical conditions like HIV or cancer, non-cancer chronic pain, can also be used to help things like insomnia, agitation, that kind of thing. So interestingly, you go through all the research and you see all this information about how it's used mostly for chronic pain. And then you go to the websites of pain clinics, which are, there's quite a few of them in Toronto and the GTA. And when you go onto the pain clinic websites, which are run and they're run by physicians, okay, who have special licenses to prescribe medical marijuana, they list, there's like tons of things that they treat medical marijuana with in the appropriate situation. Okay, so anything from eating disorders to post-traumatic stress disorder to anxiety to insomnia. So I think that, over the last 4 or 5 years, the evidence and the research behind medical marijuana has really ramped up. We're probably going to see a lot more of it, in the next little while, in the next few years. Hopefully showing, where it can be used appropriately. But again, the main message is this: if you're going to use medical marijuana, it's like anything else, right? It should be done through a medical practitioner. So how it works is let's say, you think you're a candidate, okay? And a lot of these websites, when you go to them, and I'll give you a list of a few again in a sec, they'll kind of give you like a quick survey, like, are you an appropriate candidate for medical marijuana? You kind of look at them and you decide if you are, you can contact them. But the physicians who work at the clinics, you have to fill out a form, or they have to fill out a form called an ACMPR, which is an acronym for Access to Cannabis for Medical Purposes Regulations, okay? And basically that will allow the doctor to prescribe you medical marijuana, which is obtained through the Health Canada licensed producers, okay? So this is it's a regulated system, okay? Because the effects of CBD and THC in different people vary greatly. So let's say I wanted to use it for something, okay? Let's say I wanted to use it for osteoarthritis and Chris wanted to use it for osteoarthritis. We could have the same level of pain, the same level of disease, but our doses could be entirely different, okay? So it's very patient specific. It has to be tailored because oftentimes there's a combination of CBD and THC in the formulation that you're going to require. Usually you start off with a very low level of THC. And then depending on your symptoms and your follow-up with your physician, that would be titrated appropriately. But it is definitely something that should be done carefully through the advice of a medical practitioner who specializes in medical marijuana. Okay. So for example, I know I have a patient who's a transplant patient. She had a double lung transplant many, many years ago. She has a whole slew of other medical issues, probably partly because she's on a lot of immunosuppressant medications. So, she's kind of developed other issues secondary to the treatment of her transplant, but she's alive. She also happens to have severe spinal stenosis. So, I sent her to a pain clinic and unfortunately, she didn't tolerate it, but there's an example of somebody who was a good candidate initially to at least try medical marijuana for pain purposes. I have another patient who also has chronic pain, excuse me, shoulder injury, chronic headaches, and is also treated with medical marijuana. Because the other aspect that we have to look at here is, so two things. Sorry, I feel like I'm jumping a little bit, but number one is medical marijuana should be used as an adjunct to other treatments. Okay, so when we're talking about medical marijuana, oftentimes it will not be your first line of treatment, right? Even for pain conditions, there's a whole slew of pain treatments that we can use that are very effective. We have a lot of research for anti-inflammatories, anti-epileptic medications, neuropathic pain medications, cortisone injections. CBT is used for chronic pain, right? It's a very psychosomatic condition. How do you deal with chronic pain? Because chronic pain is chronic pain, and you're going to have to live with it. A lot of patients have to live with it. So how do we get you to learn how to cope with it? Because it's not, in a lot of cases, we tell patients, this is not going to go away. We cannot take your pain away. What we can do is help alleviate it a little bit, and then help you cope with it. So the medical marijuana piece of this is part of your treatment, okay? I think the other part that would be nice to see is this whole kind of thinking behind, can we reduce the risk of opioid use by substituting or implementing cannabis use, right? And I'm sure everybody's aware, in the last few years, we've had a huge spike in opioid use and deaths. Okay, there's like an opioid crisis, which is very unfortunate. So can we use cannabis as part of our armamentarium for chronic pain to avoid the, potentially very dangerous side effects of opioid use, which occurs in a lot of people because they just want to feel normal again, right? Their pain is bad, or whatever they're using it for. So I think that, I think, Chris, when you asked me last week about CBD oil, in my head, I was thinking topical stuff. Topical stuff actually has very little research behind it, right? It's just, we don't know how much I absorb if I'm putting it on, like almost like a pen said, right? Like a topical pain medication is going to be very different than, let's say, what Margaret's body absorbs and utilizes. But when we're talking about medical marijuana, there's a huge kind of, area that we have to explore and research, but I think it definitely does have its role. But again, this is not something that we should just be kind of going online and, ordering whatever from wherever, right? We have to remember, this is used for medical purposes. We have to, the best thing to do is to obtain it from manufacturers that we know, where it's regulated, where it's dosed appropriately, so that it's not going to cause harm, right? We're trying to minimize harm. So if you guys want to look at anything else, there's some really good websites. So Health Canada has a whole section on medical marijuana. I found a lot of interesting stuff on the Arthritis Society of Canada. That was another really good one. There's the Canadian Pain Society. And then there's a really good one called the CCIC, which stands for the Canadian Consortium for the Investigation of Cannabinoids. So those are really good websites that you can go to for some evidence-based stuff, right? Stuff that has research behind it. And that's probably all I have to say. Again, I'm certainly not a pain specialist. I don't prescribe. I don't have a license to prescribe. Do I refer patients when I think that they're appropriate candidates? Yes, I absolutely do. But I think it does, and it will establish its role in, therapeutic use over the next few years.
Sorry, just to clarify. So so GPs can't prescribe, only pain specialists specifically can prescribe opioids.
I think a GP can, but they have to have the you'd have to be specialized in pain treatment. Like, you would have to have the license to prescribe.
Okay.
So it doesn't mean a GP can't do it. But they have to be qualified to do it, as far as I know. It's
one of those things, because it's still so new. Obviously, you guys will feel more comfortable going to a pain specialist, but it's going to become like every other drug. When you guys have enough of a track record, you guys will be prescribing different variations of opioids after, or no?
Yeah, I mean, I think it's possible. I think, right now, like, for example, for me, it's very overwhelming, right? To have to deal with that on top of everything else. It's because my whole goal is that I don't want to, my goal is to not harm people, right? And so unless I feel really confident in the prescribing mechanisms and the dosing and all the stuff that kind of comes behind it. But is it possibly going to become more sort of like mainstream for GPs? I think it could in the next few years. The thing is for us, it's not difficult to obtain that education, right? I mean, we can, if you have to remember too, where treating chronic pain is it's not an easy thing to do. So chronic pain patients have very, very different issues, and they're important issues than your regular, patient who comes in with their high blood pressure, depression, whatever, bread and butter kind of medicine stuff, right? A lot of times chronic pain, it's a complex condition, and there's a lot of other issues that come with it. And so it's not just about the prescribing of the marijuana. It's about dealing with that patient as a whole, right? How do I deal with their pain, but also all their other issues? And for some physicians, that's just not their, it's not their thing. They just, it's not what they choose to focus on. Like I might choose to focus on geriatric medicine. Somebody else might choose to focus on, chronic pain. It depends.
Is there a process before prescribing them what drugs where you guys try to like treat them psychologically as much as you can before, or is it just like
100%.
take the drugs and that's it?
No, 100%. At least that's what should be done, right? So a patient with chronic pain comes in to see their doctor. It's a process, right? Number one, we have to understand the pain, how it was caused. Number two, what kind of pain is it? Right? Is it acute chronic pain? Is it pain from a medical condition? Is it a somatic pain? Is it neuropathic pain? Because the different types of pain can be treated differently with different medications. So, the one patient that I was talking about before with the shoulder injury and the chronic headaches, I mean, he's actually been doing therapy, like cognitive behavioral therapy as part of his pain treatment. Because again, it's about coping with the pain. So it should never be a process where you go and you see your doc and you're given a prescription for a medication and off you go. Right? We're always trying to find the best solution from all avenues. Sometimes it's hard, Do
you find it challenging because of the way the healthcare system is set up with the amount of time you have per client and all that stuff, where it's like, okay, well, I can only treat you for this much, and I know that I can't give you the proper support that you need, so take this in the meantime, right? Like, is it a fine balancing act, or it just really depends on patients? Like, I guess because there's so many different levels and different areas that people come from.
It does. It depends on the patient. It depends even on their other medical conditions. Like, for example, if I have an older patient, let's say, who's got chronic pain, but they also have a bunch of other medical conditions, I may not feel comfortable prescribing pain medication because I don't want to give them a gastrointestinal bleed. I don't want to worsen their kidney function. I don't want to worsen their hypertension. So there's a lot of other factors you have to look at when it comes to treating, pain. But, does CBD, can you hear my dog? Does CBD have a role in that? Do cannabinoids have a role in that? Yeah, I mean, they could, right?
Is it easier to prescribe that as a, prescribe that first and then go to other types of drugs that might be a little bit stronger? Or is it something that you'll just take that in conjunction with other types of drugs? Like, is there a process that people go, or again, it just really depends on the individual?
Yeah, it always depends on the individual. It always depends on the individual. But I will say that very, very rarely, I would say, would medical marijuana be your first choice of treatment, right? It's not going to be the first thing we go to because, we know a lot about other medications, right? We know which medications work. We know their side effects. We've used them for years and years and years and years. We know exactly who they're going to help and who they're not going to help. So it would be very, very rare to have a patient only ever tried on medical marijuana as a first line therapy for a pain condition. Very, very rare. It would always be used, like I said, as an add-on, right, to their other to the other therapies that they're using.
Is it something that people will bring to your attention while they're like, hey, I'm on these drugs, but I also heard that, especially now because it's so trendy and everyone hears about medical marijuana, where they bring it up to you, or it really hasn't changed anything since it became legalized?
No, I would say people do ask more frequently, because they know about it now, and there's a lot of information out there for people nowadays, right? It's very easy to find information. Whether it's good or bad information is a different story, but a lot of people will come in asking about it because they know about it. And that's a good thing, right? As physicians, that's a good thing. I don't mind that. But again, it's finding its role in treating that particular person, right? Is this, number one, a condition that we think it's going to help you with? What other things have you tried? You know, are you a good candidate? And then if you are, how can we incorporate it into your other, you know, into your other treatment modalities? How can we use it as an add-on?
Can you talk a little bit more about like actual CBD oil? So whether it's like the there's like, I know there's like a million different dosages, like some of them 1 drop equals 50, I don't know, what is it, milligrams, and then some of them the same drop is like 25,000 milligrams or something.
Yes, which is exactly why I'm saying, if you're looking at this as a potential treatment for yourself, you should always be doing it with a medical practitioner who does this, because the dosing, not only do the dosage, not only do the doses in the supplied product vary, but again, what you need is going to be very different from what somebody else needs. So number one, what form of CBD is beneficial for you? Number two, what dose of CBD should you be on? How frequent should you be using it? You know, the other thing was just in terms of prevention, because I know Chris mentioned this yesterday during class about CBD oil, and you know, has he noticed anything? Sort of no, but maybe it'll help in the long run. We don't really have evidence for it to be a preventive treatment, right? Right now we're implementing it as a treatment for people who are experiencing symptoms. So you know, that's the other thing to keep in mind. But yeah, I mean, it comes in dropper forms, it comes in, and that's the other thing. How should you take it? You know, and that might be also related to what your lifestyle is like. So it comes in melt away forms where you put them under your tongue and they dissolve. It comes in oil droplets. It comes in capsules that you just take like a pill. But that is very individualized per patient. So it's very important to do this under the guidance of a medical practitioner who is experienced in this, right? And remember, the sources of cannabis they're using are coming from producers where we know that it's, you know, meeting certain requirements, and we can track dosing as opposed to just going online and ordering it from wherever and then not really knowing what you're taking.
Do you think there's any, like, not negative side effects, but it's almost like one of those things, it's like if you just take it, maybe it doesn't do anything, but it shouldn't really cause any harm, and maybe it does do some benefit in the long run, like if you just stay consistent with it?
So this is my thing, right? This is, and maybe I'm talking probably not with a whole lot of evidence behind me, but you know, last week we were talking about vitamins and minerals and what happens if you take too many and you don't really need them. Well, your body excretes them, but we know that. We have the science behind that to show that, right? CBD to me is different. It's a lot newer. We don't have the amount of research on it that we do on a lot of other substances. So to take it and not feel anything from it, but be like, well, it's probably not going to hurt me. I don't know that we know that yet. You know, I don't feel comfortable saying to somebody, well, it's probably not going to hurt you, so go ahead and take it. We don't know that. I don't feel comfortable knowing that we have that kind of evidence strong enough to say, it's okay, go ahead and take it. Maybe it won't hurt, maybe it won't, but can I say that for sure? Not really. Again, it's, you know, it's not, CBD itself is not psychoactive. So you don't have the potential for abuse isn't there. But again, you're putting it into your body. Is it reacting with other medications? Is it, you know, is it doing things that, you know, with, especially, I'd say the biggest concern there is interactions with other medications that could potentially cause problems. So it's like, you know, it's like, to me, it's like saying, well, I don't have pain right now, but should I take some Advil just in case? No, right? Like, you don't need it right now. Why put something into your body that you don't need right now, you know, without the evidence to show that it would help you in the long run? I just, personally, I haven't seen strong enough support to use it in that way.
Doriana, this is Chris from Timmins. I really like how this relates to fitness, if I'm looking at it from that point. When it comes to my clients, exactly what you just said, like, I tell them never, if they have an injury or some pain, to not take Advil when they're coming to work out with me, because then it disregards their, I want to see the compensation so that they realize they're not a superhero. Where I guess what I'm trying to say is, yeah, the same with when it comes to the cannabis that you're talking about. I know a few friends, I mean, I've been in fitness a long time now, who will take it for pain from working out, but that's nothing to do with neurological. That has to do with our, you know, the torn muscle, letting the satellite cells get in there to repair the muscle. The only way to speed that up is with testosterone, rest, proper nutrition. But people will take it thinking, well, I got to get rid of this pain so I can work out tomorrow, but it's not quite the same. So I guess what I'm trying to say is a lot of people, you know, like I know, will use cannabis to, you know, to dampen the pain from the workout before, but then they come in and they're not feeling anything. So now they're a superhero deadlifting 400 pounds, and then they really destroy their back, and because they didn't realize they were compensating the whole way. So when it comes to what you were saying, the people with chronic pain and opposed to workout pain, do you notice that it's mostly neurological chronic pain that cannabis seems to help a lot?
Yeah, so that's exactly it. So I think what you're talking about is masking those symptoms, right? Are you just masking symptoms and then possibly going and re-injuring yourself? That's different than, for example, like I tell patients quite often to take Advil or whatever pain medication they've been prescribed, for example, before a physio session. But I know what their injury is, right? So they're not going to just randomly do something. I'm giving them the anti-inflammatory prior to their procedure so they can tolerate it, because the idea there is that the procedure is going to help them, right? That session is going to help them recover better. But there's definitely more evidence for the chronic pain. So we're not talking about acute MSK pain for medical marijuana. That is not the indication. It's for chronic pain. Chronic pain resulting from a lot of different conditions, but it's the chronic pain. And I'm going to hazard a guess and say it's because chronic pain, like I said, is a totally different, complex pathway than acute pain, right? Chronic pain is a very complicated pathway that involves, you know, the central nervous system and how those messages are sent back to the brain, right? They've been really rattled up with chronic pain as opposed to acute pain. They've been kind of messed up in a chronic pain condition. So yeah, I mean, I agree. I think in your case, you're masking symptoms and then possibly re-injuring because you don't feel it when you're doing your workout.
Perfect. Thank you.
Doriana, so you were talking about like obviously marijuana is better for chronic pain. With chronic pain, obviously you have like marijuana is one, and then you have like opioids is kind of the opposite end of the spectrum as far as like how it treats things. Is there like, other than maybe like, you know, Advil and Tylenol and over-the-counter stuff, is there other things that don't fit into the opioid category but that you would go to first for chronic pain? Because I feel like, especially now, we're realizing like chronic pain and opioid use, you know, it might be good for the first 3 months, but you ruin the guy's life in 5 years because it's, you know, not leading to good places. So what are the other options before marijuana that, because it's like marijuana seems to be pretty safe, even if it doesn't work. Like there are obviously risks with everything, but the risks are significantly lower than, you know, Vicodin, for example.
Yeah, for CBD. Remember, right? Because marijuana, we're talking about CBD and THC, but don't neglect and don't discount the long-term side effects potentially with the THC part, right? The cognitive impairment, the short-term memory loss, if you're smoking it, the lung damage. So there are side effects there, but you're right. And I think that in terms of opioids, as a physician, I get angry sometimes at other physicians, whether it's medical doctors, dentists, because I see opioids being prescribed like, you know, for tooth pain. And I'm like, yeah, okay, I get it, but they don't need a 60-day supply, right? And then I'm the one dealing with trying to wean them off after, or I have to send them somewhere, or, you know, it can be a real problem. And it has definitely taken a turn for the worse in the last couple of years. So there are definitely other things that we use for chronic pain. So when we talk about chronic pain, again, it'll always depend on the condition causing the pain, but you've got your anti-inflammatories, you've got your good old acetaminophen, right? Which I use a ton of in my older patients who don't have liver problems, because you can take up to 3 to 4 grams of Tylenol a day, and that is safe for a lot of old people, and it's not going to give them a GI bleed. It's not going to get them addicted on anything. Then you have your other medications that are kind of like this cross between an opioid and Tylenol, Tramadol, Tramadol. It's still, I would say it's still considered an opioid, but then there's, we can't forget about other classes of medications specifically for nerve pain, neuropathic pain, which can be really debilitating, right? There are anti-epileptic medications. So a common one that we use a lot of is called Lyrica, or the generic name is pregabalin. So Lyrica is a medication that specifically targets nerve pain. Nerve pain is different than regular pain. I don't know if anybody here has experienced nerve pain, So think about your shingles, like somebody who has shingles, or somebody who has diabetic neuropathy. But nerve pain is described as this electric shock-like pain. And it burns. It's a burning electrical pain as opposed to like a muscle pain. So there are the anti-epileptic medications for that. There's also, we use a lot of old school antidepressants called Tricyclic Antidepressants, or TCAs. Those are used a lot in pain conditions at different doses than they would be used for mood disorders, but they can be very effective in pain as well. And then there's also, I don't know if anybody's heard of Cymbalta. That's the brand name of it, but it is, it's actually an antidepressant, a newer antidepressant, but it has anti-pain properties. So again, mostly with neuropathic pain. So I would use all of those or any of them before I'd go to an opioid, right? Again, I mean, if you're post-op, of course you need an opioid, right? But I'm talking about these chronic pain conditions. And I think that, you know, why not throw in some CBT? Because if your quality of life is being ruined because you cannot cope with this chronic pain, then part of that is going to be learning how to cope with it. So it's not, that for sure is not going to hurt you, right? So I think a lot of that is going to be, should be, you know, they should be accessed before opioids.
And then, is there ways that like obviously there is, so just if you could go a little bit deeper in like how certain treatments work versus other things. So you kind of said like opioids are really, really good for post-op care, which I experienced before, versus like I have like cluster headaches, which seem to not respond to opioids at all, which like I took some and it was like I might as well have had like a Tylenol, and I was taking something that like knocked me on my ass when I had like, you know, my Achilles surgery done. So is there reasons like why certain treatments like work on certain pains versus other pains?
Yeah, I mean, again, the deep physiology behind it, I probably can't get into, but again, so for example, migraines, right? Migraines are a good example, not so much cluster headaches, although cluster headaches, one of the treatments I know for cluster headaches, and again, I don't know why this is useful, but I have a patient who has cluster headaches and he was put on like oxygen therapy. So I don't know how his actually, like, I guess he had some sort of mechanism to use at home, but it must have to do with some vasodilation that happens, right? To alleviate his cluster headache pain. But again, that's a very specific type of pain that needs a very specific type of treatment. But for example, migraines, right? I mean, we have guidelines on how to treat a migraine headache. And the guidelines are you start with an anti-inflammatory and your Tylenol. Then you go from there. You know, then if you need something stronger, we can go to, again, depending on the nature of the migraines. Are they chronic migraines? Because if somebody's getting migraines 3, 4, 5 times a month, I might put them on a prevention type of medication, like a beta blocker. So that would prevent them from getting the migraine. And I'm not treating their pain at all. I'm trying to prevent the migraine. But again, yeah, it depends on what kind of pain it is. So, you know, the anti-epileptic medications, why do they work for neuropathic pain? I mean, I don't know. Obviously that's at a very, very cellular level. And it's that, you know, it's that pathway that goes along the central nervous system that's causing that type of pain. And there's obviously, you know, that medication will block those, it's called nociceptive pain. But those receptors are blocked or whatever. But yeah, treating pain, it's not a catch-all. It's not like a big, you know, web that we just throw everything into. So, which is a good thing because sometimes, you know, depending on the type of pain the patient is experiencing, we have very specific treatment for them. I'm trying to think of any other example. Shingles, right? Shingles pain. So when I see a patient with shingles, first thing I want to do is put them on an antiviral to make that course of shingles as short as possible. But I don't know if you guys know anybody who's got postherpetic neuralgia, which is the nerve pain that can last after shingles goes away. So the whole reason we treat it really aggressively initially, and we say to them, as soon as you see that rash, you want to come in and see your doctor, is because it also reduces the chance that they're going to be left with nerve pain. So once your shingles rash goes away, you can have that nerve pain forever. And then we treat it with the anti-epileptics, the TCAs, the tricyclic antidepressants, because we know it's a nerve pain and it reacts better to those type of medication. I wouldn't put, you know, a postherpetic neuralgia patient on opioids because they're possibly going to have that pain for the rest of their life, right? So that wouldn't be appropriate.
How about when it comes to herniated discs? I've had it twice in my life now. The one time I had it really bad was in 2008. I had it for a year, and like it was horrible. So for a year I was taking, not that this is the smart thing to do, but the only way I could go to work, because I was a personal trainer in Toronto, was taking 1,200 milligrams of ibuprofen every 4 hours for a year. And the minute it would wear off, I would almost bend over in front of a client and crawl myself to my office to take it. And then it would take about maybe 15 minutes for the liquid gels, Advil to kick in. So that one being neurological, back then there was no medical marijuana. Would that have helped that situation?
Possibly. I'm sure that you would have been a potential candidate for it. But again, so herniated discs is another common one, right? I have patients come in to see me all the time. Well, I have a history of a herniated disc. Herniated discs, you will find in patients. If I do CTs or MRIs on 100 patients, I'm going to find patients who have herniated discs who are not bothered by them at all. So there's a difference between having a herniated disc and having a herniated disc that's actually causing pain. And the reason that they usually cause pain, especially if you're having the neurological type of pain, is because that disc is now bulging out and it's hitting the nerve that is coming out of your spinal cord at that level, right? So oftentimes with a herniated disc, you'll get neuropathic pain because it's hitting the nerve, and you get that kind of sciatic type of pain. I don't know if that was the kind of pain that you were having, Chris.
It was a sciatic nerve, and definitely coming from the L4, L5. I understand that it could be going through your piriformis too, so it could go under, over, and in certain cases it goes through. But yeah, I was shooting straight down my left leg, which is funny because when I first went to the physio, because I did it when I was playing basketball, I just jumped, threw down a dunk. When I landed, it felt like my hamstring had snapped. So everyone was trying to treat me with a torn hamstring. So I was stretching on cold. And then when we got the MRI back, it was my, pretty much one of the scariest days of my life. But I had stenosis, degenerative disc disease. I think everyone just has these things. And then herniated L5, but disc bulge L4. And it was the bulge that was pinching on the sciatic nerve. And any flexion forward would just drop me to my knees.
Right. And so it's good that you had the MRI, right? Because an MRI showing that in conjunction with and in the context of you having symptoms that neurologically make sense, because the pain is along that pathway of that particular disc. That's a good diagnosis, right? As opposed to saying, oh, I have back pain, I'm going to treat you like you have a herniated disc. But in terms of herniated discs, the biggest thing there is an anti-inflammatory. Because what you're trying to do is to get the inflammation down, right? If we can settle down the inflammation, and that's why the Advil was helping you. Unfortunately, you had to take so much of it, which of course has its own potential side effects, right? The biggest one is having a GI bleed when you're on it that much for a year. It's fine to do it for 2 weeks, a month, but it does have potential side effects after that. But yeah, so definitely you would be the kind of person I would definitely try on Lyrica and say, okay, we know where this is coming from. We know that it's a nerve pain caused from this disc. That being said, most of the time, sciatic type nerve pain, even if it's from a herniated disc, a lot of times the inflammation settles down within about 6 weeks. If it doesn't, then that's usually when we go to imaging. And then in your case, if we had seen that, I would have, done the anti-inflammatory. I probably would have tried you on a neuropathic type of pain medication like Lyrica. And then there's other options after that, right? Depending on age and severity, do you need surgery? Nowadays, medical marijuana, would that have helped you? So yeah, I mean, I think if it had happened to you now, you might have had a couple other options that would have helped.
Awesome. Yeah, because then I just started doing the exercises, and when I was on the Advil, it would subsidize the acute pain so that I could go into using yoga to force the disc in. I really wanted to stay away from surgery. So yeah, I was kind of interested in how the cannabis would have helped that, or the CBD oil. Okay, thank you.
Yeah.
I have a question. Is there a link or any evidence or any kind of research that demonstrates a link between either so I know that there's medical marijuana and then there's CBD as a component of that. So is there any research between either CBD or medical marijuana and dopamine production?
Oh, the short answer there is I don't know. I did see a little bit of talk about dopamine in some of the articles that I came across, Jordana, but I would have to look at that as a specific kind of entity, right? And are you referring specifically to dopamine and mood issues with it?
Just any kind of, I guess, chronic condition that's associated with dopamine. So whether that's mood issues, whether that's things like Parkinson's or whatever, stuff like that, like where the link would be between the two of those and the evidence in that.
Right.
Because I know that dopamine production is linked to a host of different chronic illnesses, right?
One is Parkinson's, people will think of with dopamine, right?
When I read, they said it was like a mild version of an SSRI.
What?
An SSRI. With CBD oil, like a mild version, which will affect your mood, obviously.
So an SSRI is a selective serotonin reuptake inhibitor, and
right.
antidepressants, basically, like the newer class of antidepressants.
And
but
then
that's I don't know about the dopamine, Jen. I have to look that up.
Okay.
And they said your mood would change because adenosine is more prevalent. Where like when we take caffeine blocks adenosine, so you feel more awake, right? And they say it's the exact opposite effect when you take CBD, which will give you more of a calming effect, not to the point that you want to feel sleepy, but they said it's the effect of relaxation, which in turn should be changing your mood to make you feel better. We're saying, but that's about it that I know of. When people take CBD oil, do you think people think that oil like is like going into your in your body and then like it's a direct cannabinoid? Not cannabinoid. What's it called? Sorry. No, cannabinoid. Yeah, cannabinoid. Because it like people, I think people think that CBD is a cannabinoid when they say it actually, what is it? It actually just promotes your cannabinoid. I can't even say it. Cannabinoid process in your body. Like it naturally produces more of it, so it creates more availability inside your body. It's not actually you're ingesting cannabinoids that go into your system.
Yeah, I think it's the fact that the CBD is going to interact directly with your CB receptors, right?
Yeah, exactly.
So essentially, you're taking an exogenous form of cannabinoid.
I know it's a tongue twister over here. Cannabinoid, whatever.
But yeah, and then don't forget too about the whole placebo effect, right?
Well, I know some people, they swear by it, like my life changed, I sleep amazing, I'm so much calmer, blah blah blah, and I'm like, I want to feel those things, but I don't, right? But then again, I guess it could be like, again, if they think that it's working, it's working. So that I'm not even a question. That's good for you. Like I'm jealous.
Right.
But do you think it's just, again, depending on like your age, your health, your lifestyle, they'll be more sensitive towards it compared to someone who's already regulating a homeostasis kind of thing?
It's possible. It's possible. I think it's hard to say. It's hard to say which patients are going to have a really robust kind of response to it and which patients are not. There's so many, things at play right down to a cellular level. Like why does one patient have such a good response to it and others don't? And then, even looking at the way the studies are done, right? You have to make sure that studies are done, randomized, double blind, placebo, you've got to have your placebo arm. And then even down to the point where, I was reading about how some studies, for example, I think, so there's what they call an open phase. During an open phase of a trial, patients who are experiencing really negative side effects are removed from the study. Well, of course that's going to bias your results, because then you've got a population that you're studying that are not having negative side effects. So there's all those things to think about when you're looking at, and that's why I keep saying, just be careful about where you're looking up your information, right? Because you can read that there's studies and meta-analyses done, but are they, that is not the same as looking at a really well-run, controlled, double-blind, randomized controlled trial. So.
On that, I know Chris has also read the book How to Change Your Mind, which is about more like psychedelics, and they don't talk about marijuana at all. But there's like a part in it which is hilarious where they talk about the difficulties of testing these in a double-blind study are obvious, because if you give half of a room LSD and half the room not LSD, like you immediately know who got LSD. So like the people watching it can't be like, well, let's see how these, like group A reacts, let's see how group B reacts, because it's so clear. I feel like you'd probably have the same issues with THC if you gave like half the room like an edible with, you know, an active compound in it, half without it. So do you think there's going to have to be a point where they reevaluate how they're testing these things? Because like a double-blind study won't work on something that's super active in that way that it would work on like something that's not. Just, you know, like anyone that's taken like way too much THC is going to immediately know what they're feeling like. There's no way around it.
And that is exactly one of the things I read about. And I can't remember what they called it, but it's basically this concept where if you're doing studies in patients who are not naive, right, they're going to be aware of the effects of THC. So it is difficult to blind those people, right? As opposed to taking somebody who's naive to it and they don't really know what to feel. So yeah, I mean, you're going to have, that does come down to how are you going to do these studies? How are you going to make sure that it is, you know, double blind? People, you know, don't know where they're going. And so you have to account for all those variabilities, right? I mean, that's the basis of a good scientific study. You have to have, everything has to be the same except for the one thing that you're trying to measure. And that's not an easy thing to do necessarily.
So how would you, but like, wouldn't that lead to a point where you just couldn't test certain things under the same definition? I mean, like, if we use an extreme example of something like, I mean, THC at high doses would work, right? If you have, I don't know what a strong dose is, but like, you know, say whatever someone takes at a party, if you give them 3x that, and then you give someone else something like a non-active, like just a regular gummy bear, it's going to be one, apparent to the person, but it's two, it's going to be really, really apparent to the people studying it. Right. That's what's going on. So it's like you would sort of be like,
okay. But that's okay. Double blind. What the piece that you don't want to know is who is getting the active component and who is not getting the active component. Because even if I'm doing a study with blood pressure medication, right? Physically the results aren't there, but I'm still going to be seeing robust results when I'm taking those measurements. It's the fact that the studier cannot know who's getting the active component, and the person in the experiment cannot get cannot know if they're getting the active component. But and again, like I am certainly not a researcher, but you would have to make sure that your patient population is the same. So to do a study where you've got some people who've used THC for 5 years and run that experiment also containing people who have never used it before, I mean, that doesn't constitute a very good, base where you've got, you know, everything the same except for the one thing you're trying to study. I think that's what you're saying, right, Rob?
No, more that like you would be
hard to, it would be hard to
even for like a person that didn't know. Like if you gave me two, you know, like say you time this by 100, but you give me like 2 pills and one has got like a very active THC and one has no THC in it, and I give one to Chris and one to Steve, and I don't know who's got what. Me studying them it's gonna become apparent like which one is which. If, you know, Chris is like over drooling and like laughing his ass off at like a spider web, and Steve's just sitting there like, oh, maybe I feel something. Like he might think he feels a little bit, but you're just gonna see like absurd effects. So there's no way I could be unbiased saying like, oh, well, I don't know who got it, but like Chris seems to like get more of a response. So I'm just curious how.
So that would be, so then I think to me, the next question would be, well, what's your endpoint? What are you looking for? Because you might know just by looking at them who's had it and not had it, but then what is it that you're trying to study out of those two now, for Steve versus Chris? And is what you're studying going to be, what am I trying to say? Like your endpoint, is that going to be irrelevant as to how they're physically acting? So now, okay, fine. You can see that they're acting this way versus this way, but is your endpoint, what you're trying to research and find the answer to, is that going to be the same regardless of what you're seeing, right? Like, I think that's where the mechanism of the study would have to be really, really specific. You'd have to have a very specific endpoint. What is it that you're looking for? if you can actually see who's got the active component.
Hey, Doriana.
Hey.
So with regards to placebo, you know, it's obvious, it's clear that placebo, you know, takes effect in certain situations, and pills, obviously, like placebo is not going to cure your swelling on your hand or your internal organ issue or whatever. So there's pills that are necessary for certain things. When it comes to placebo, having to do with a mind and body connection, and where a lot of this cannabis stuff comes into play and so on, you know, I find that older doctors, such as my family doctor, for example, 75 years old, knows shit about mind and body connection. He's either a pill pusher or don't do this or don't do that. But is there a change in the way your generation of docs and older generation of docs are being taught or learned of how to use more mind-body connection rather than just pushing pills?
It's being
The older
recorded,
ones,
Doriana.
Is what?
It's being recorded before you bastardize everyone.
the
So
older
if
one,
I'm working at 75, somebody come and lock me out of my office, because I will need a lot of medical marijuana if I'm working at the age of 75. First of all. Yeah. So, you know, like, yeah, I mean, it's, and I'm, yeah, I think you're right. Like, I'm not going to, you know, pool everybody into the same, you know, all 75-year-old male physicians into the same field. But hey, you know, 75 years old, you know, he trained probably 50 years ago. I mean, back then, yeah, it was like, you know, medicine was very, what's the word I'm looking for? Patriarchal. Like, this is what I know. I am smarter than you because I'm the doctor. You do this or that, my way or the highway, right? I think that was just kind of an attitude. I think that was kind of,
It's a cultural mentality, I think.
yes.
Like my parents or my grandparents, it's like the doctor is God.
Yes.
Like, you are perfect. You can never do anything wrong. You're not a human being. Like, you're here. So
Yeah.
you might say, like, this is what's wrong with you. It's like, but I thought it was my left arm, but you said it's right. Okay, that's the doctor. You're done. You're right. I'm wrong. Like, they wouldn't question you, which I don't think is fair for you guys. You know what I mean? As much as
Absolutely.
you guys know, like, it's not fair, because again, you'll be the first person to be blamed when you know, something goes wrong.
Yeah. So there's actually a lot of components to the answer here, Piero. It's the fact that, you know, even like I went to medical school in 2002. Okay. So that's a long time ago now. But I mean, even back then, you know, we were taught on a patient-centered approach, right? So our training was, you need to establish a relationship with a patient. You need to understand what their goals are. You need to help them come along to a plan based on what they want, you in conjunction with them, so that even the training has changed, right? So when I have patients come to me, at least I hope I am, again, there's going to be certain things where I just know, okay? I know the answer. You may have Googled it. You may have a friend who tried this and that, but I just know that that's not going to work, okay? But there's a lot of cases where it really does have to be a patient-physician relationship, right? This is, and especially in family medicine, because you become part of your patient's lives. So it has to be a discussion, you know, and, you know, regarding the placebo effect, like, okay, so I can't relate this to medical marijuana because I don't prescribe it, but antidepressants for me is a huge thing, right? So I have a lot of patients come in, they have depression. I feel like they're going to benefit from an antidepressant. They are adamant that they are not going to go on an antidepressant. I have to work with them. I cannot force them to take it. I can give them all the information, and I'll tell them, if you change your mind or your mood gets worse, make sure you come back and see me. We'll talk about it again. And we have a conversation about the placebo effect, you know. You might start this antidepressant and feel better in 3 days. I know that that's not the medication working, but if you feel better and it's a medication that I know is regulated, I know exactly what I'm giving you, I know, you know, what potential harm there is. Hey, you know what? I'll take it. If you feel better, why not? So yeah, I think that unfortunately a lot of that old school mentality thinking does still exist. And that's kind of unfortunate, right? Maybe it's just time for him to hang his hat.
I think that's a double. Oh, sorry.
No, go ahead.
I was going to say, I feel like that's a double-edged sword for you, Doriana. Like, nowadays, even just my clients coming in watching some, I'm sorry for the language, but bimbo on Instagram who's just got a booty and someone filming him, and they'll come in and say, Chris, I saw this exercise she was doing. Let's go ahead and do it. And I'm like, Vivian, you're 70 years old with chronic pain in your knees, and I don't really know if hanging from a chandelier, swinging backwards, landing into a squat is the best thing for you. So what I was going to say is,
account, please. I want to start following her.
yes, instantly. That's why I call it Instagram. No, but what I was going to say, I feel like that would be a huge double-edged sword for you, Doriana, because now you got young people coming in, and they actually think they're better and smarter than you. Well, hey, man, I Googled it yesterday, and it looks like I just have to take 16,000 milligrams of TDC oil, and I'll be perfectly fine. I just cured my, my fibromyalgia.
Yes, and it is. Some days it's what almost breaks me, right? Like I come home and I'm just like, I cannot have these kinds of conversations anymore. Because there are patients who come in and they say, hey, Dr. Parkin, like, this is what I found online. Like, tell me what is behind this. And we have a conversation about it. That is totally cool. I am totally up for that. That's all about educating people, working together. And if I don't know the answer, I'll tell my patients, I'm going to try and find out. As opposed to somebody coming in and saying, I need an antibiotic because I know that I have an infected toenail from my sinus infection last week. No, you don't, but I'm not leaving without an antibiotic. Okay. So that's different, right? Like that's a whole different relationship. And yeah, it can be a double-edged sword for sure. Any other questions, guys?
We're over an hour right now.
Again,
and
oh my goodness.
we've definitely gone into other areas right now.
Yeah. So I'm gonna leave it because again, that's about all I have to say for the medical marijuana part. I hope that the websites, if anything, if you want extra information, those websites should be helpful. But yeah, if any other questions, then let me know. I'll try and look up the dopamine thing, Jordana.
Cool. Awesome, guys.
Thank you so much, Doriana.
Yeah, that was awesome.
Thanks, Doriana.
Hopefully everybody enjoyed it. Again, thank you. This is week 4, and I think that's
Love it.
a lot of information for a lot of people who wanted to know this perspective. And I think the good thing to take home is that it's not a one size fits all, right? And I think that's important because it's not like more is better. And if this guy's like 20 years old taking this, and this guy's 70 years old, he's probably should be taking the same thing because we're buying at the same store, and it's definitely not the case. So.
Exactly. Yeah.
That's good to know. But sorry, just again, something I'm thinking about right now quickly. So would you guys prescribe CBD oil, and how much for someone to take? Like would a pain specialist prescribe CBD oil, like, and how much to take? Like how many milligrams, really? Eh? So it's not just go online and find a deal.
No, you should be asked. So yeah, definitely. If you are interested in this and you think you're a good candidate for it, you need to ask your doctor, your family doctor, and if they don't do it themselves, they will refer you to a pain clinic. Okay, so there's definitely a route to go. All you have to do is ask for a referral.
Okay, cool. So kind of like the same kind of thing, like say I felt like I had low hormones and I need, again, GH. So like the same kind of clinic or same kind of deal?
Same kind of deal. Always, your family doctor is your gatekeeper, right? So they're going to assess you. They're going to figure out what the issue is. If they can help you, great. If not, they're going to send you off to somebody who can.
Awesome, thank you. Cool. All right, guys.
Can you write me a script? Can you write me a script right now?
Would you say, Piano?
Can you write me a script right now?
You stubbed your toe, didn't you?
Your mom's
Mom, great timing. Oh, you're on for the workout. That's fine.
My daughter's 25 years old, so can you write me a script? Have a good one.
See you guys.
Bye, guys.
See ya.
Bye.
Oh, we lost him.
Morning.
Morning, Anna.
Morning. Oh, I guess I got my lead. Okay, let me organize this. Oh, can you hear me?
Yes, I can.
Okay. All right.
Next,
You have to plan where I'm supposed to stand. Yes.
I don't see your head. So,
Pardon?
where you were standing before, it would cut off your head, but I could see your feet.
Is this okay?
Oh, the screen just froze. Sorry. Let's see here.
Yeah. Okay, let me figure this out.
Let me speaker view. I see your chin now. Oh, yeah, there you go. Perfect.
Okay. Just gonna, okay. I gotta move this back.
The red square, the second red square.
Wow, I don't know why it's
Now,
better this morning.
I think tilt the camera a little bit further up.
I go, hold on, let me see.
Sure. I can't get it to project.
If I do this.
Let's
Worse.
see. Is the screen? Hold on a second. Let me just help her calibrate. Let's see here.
This morning, I don't know why I can't get it to work today.
Tilt your camera a little bit higher up.
Okay, hold on.
I'm gonna have my son help me now. Okay, what do I have to do? Get out of this? Okay.
Nope. Okay, let me see my legs.
That looked really good.